Thank you so much for joining us this morning. I was doing my preparation last night, and I ran across your budget figures, and if they are correct, you're the trillion-dollar woman. How many, so $1 trillion budget, if you're not in kind of defense, is huge. Does that get you more respect in among the Trump crowd that you have a $1 trillion budget?
Well, I wish it was my shopping budget,
Yeah.
but it's not. It is. It's one of the largest budgets, and we serve over 130 million beneficiaries between Medicare, Medicaid, and the exchanges. So I always like to say what happens at CMS sort of impacts the entire health industry because we are the nation's largest insurer.
It's hard for me to think, in my role at the Atlantic and my privilege of going around the country, of a more important set of issues than cost and access in healthcare, and I know that that's very much on your mind. What are the things that you're bringing to that you think are making the overall system less wobbly and trying to address the issues of rising costs of healthcare and the concern people have about access?
I think you brought up the main point, or what I would say is the most significant issue in healthcare is the cost of healthcare. When I think about what I wake up in the morning and think about when I go to bed at night, this is what I'm thinking about. Our healthcare costs are soaring. By 2026, it's projected to be $1 in every $5 will be spent on healthcare. And so if you think about that at a macro level for government, that means governments, whether it's the national, federal government, state, and local, those are dollars that aren't going towards education, infrastructure, job creation. For businesses, that means it's less money for them to invest. And for each and every one of us, that's 20% of our household budget on healthcare. That is simply unsustainable. And if we think about over the last 10 years in healthcare, we've done a lot of regulation, we've expanded access with the promise that this is going to lower healthcare costs. And the reality is that has not happened.
What are the parts of the ecosystem that are not falling in line that you need to fall in line?
Well, a couple of things I think in terms of what we're focusing on. We have a great healthcare system, undoubtedly, but we're trying to figure out what are the things that we can impact. And so I'll go through a few of them that we're sort of working on at the CMS level. I think the first one is empowering consumers, making sure that they understand cost and quality as they're making decisions in the healthcare system. The other piece of it is that when we look at what we're paying relative to other countries, there was just an article in Health Affairs talking about the costs of stents and other devices and how we're paying more. And a lot of that has to do with regulation under all the administrative costs in our healthcare system. So one of the things that we have is an initiative called Patients Over Paperwork, and it's really looking at all the administrative burden and the regulation that we've put into the healthcare system. From where I sit, we don't want to decrease access. We don't want to decrease quality. We want to increase those things. And so the solutions aren't around rationing healthcare. The solutions are around focusing on cost effectiveness, focusing on efficiency in the healthcare system. One of the other things that we want to do is lean into technology. I think that there's a future there in trying to figure out how we can deliver healthcare services in a very efficient way. For example, looking at telehealth. One of the things that we just did recently for the first time is having Medicare starting to pay for remote communication technology or telehealth so that they can talk to their doctor over Skype. We can have people take pictures of a skin lesion and send it to their doctor. I think those kinds of things are examples of how we can potentially lower healthcare costs while still improving access and quality.
So one of the things I looked at last night was Arkansas, and the work requirements have come in. Apparently about 4,000 people have dropped out of this, and Asa Hutchinson was out there saying, hey, we've got $30 million we can return to the budget. I'm just wondering, is that the right dynamic that when you're looking at, say, the Medicaid part of what you're doing, there are a lot of reasons people are in poverty. A lot of people, I think, if I may, I think there are a lot of literacy issues in terms of how to do this. What do we do better that we're not doing to deal with folks who don't have it all together, where there are challenges? And there's this worry about people that there is no further net. And so I guess it's that final net issue. Are we doing enough?
I think it's a great point, and I can tell you from my experience, I started my career working in a safety net hospital. So I worked directly with individuals that were living in poverty.
Right.
And I can tell you that anybody that's living in poverty does not want to be there. They want to have hope for a better future. They don't want to be dependent on the government. And a lot of time they lack those skills to be able to figure out what's the pathway out of poverty. And I think some of these community engagement programs that states have requested permission to implement, that's what they're all about. It's about not just saying, we're going to give you, here's your health care card, good luck to you. We're trying to say, look, these individuals are living in poverty and they need more than that. They need some incentives about improving their lives. And if we think about, where we are in our economy, economy is booming. Unemployment is some of our lowest rates that we've seen over the last 50 years. And yet you have so many people that are not working, that are not engaging in the workforce. And I think about community engagement, it's about giving them the skills that they need and matching that up with all the jobs that are available. Governor Hutchinson told a story about an individual that was had been unemployed for a while, and through the community engagement program, the requirement, he went into one of these job skills centers and found a job, and he's now earning $17 an hour. I mean, that is what community engagement programs are all about. It's about saying we're not just looking at your healthcare needs, but we're also looking at the bigger picture. And we've had a lot of conversations about things that impact health that are not just about the experience that you're having in the doctor's office, but it's about your whole life. And I think that's what these concepts are about, is helping people, giving them a pathway out of poverty.
Now, one of the trends that I've noticed that I think is part of healthcare reform, and some of it started during the Obama administration, was moving the healthcare system from essentially, I guess, a frequency deal, how many swabs you would give, sort of volume, beds, to wellness and outcomes, and looking at it. Do you see that continuing, or do you see that in jeopardy?
No, I think that's something, we talk about dealing with the healthcare costs in our system. Right. One of the things that we need to do is move towards value. And what that means is the way our system is set up, this is how Medicare is set up, largely is on a fee-for-service system, which means you go in and every procedure, every interaction that you have with the physician is paid for, instead of saying, here's a budget that you're responsible for, and holding the providers responsible for producing outcomes. So value means providing, lower costs and better outcomes. And I think that concept of value is not just at the provider level, but to some degree, as we talk about Medicaid, I think that's where we should be going with Medicaid, where we're making a sizable investment from the federal government, even for states. Number one budget item, number two, growing faster than the economy, our Medicaid budget. The same thing we should be doing with states, which is to say, hold them accountable for achieving outcomes, giving them a budget and holding them accountable for achieving outcomes for the people they serve.
Now, you've been a champion. I've read many things you've read on transparency, accountability, and flexibility. What do those mean to you?
A couple things. I think that for, what we're talking about today is sort of healthcare at the big system level, right? How do we change payment incentives around value? Creating different ways of paying providers and even the government or state governments. But one of the things that's very important to me is also impacting the experience that each and every one of us have when we go to seek care. I think that a lot of patients, as they navigate the healthcare system, are often in the dark. We don't know what things are going to cost. We don't know the quality. And we don't always have our healthcare record. And so one of the things that we've really focused on, really doubling down on this concept of interoperability, the idea that every patient should have their healthcare record when they leave the hospital, when they go from doctor to doctor, that they should be able to have their information, and that we should empower them with the information they need to make the right decision that's going to be best for them and their family. So whether it's the cost information or quality information. So a lot of the things that we are doing at CMS around strengthening Medicare program, it's about strengthening consumer empowerment and turning patients into consumers, giving them the tools that they need to make the best decisions.
Your role in healthcare is so huge, and you just mentioned health records, and this isn't in my notes, so I'm making this up. It's such a huge issue and so controversial among practitioners about how bad health records are and the inability to use them through the system. And even reading, this is across party lines, but Joe Biden's book about his son and getting cancer care, they talked about how Hunter Biden would have to take pictures and do real time to another cancer clinic, in Texas, from where they were in Boston or something like this. And so you would kind of look at these absurd situations where different hospital systems wouldn't use the data of others. You're so large, you're bigger than everyone. is there anything, outlandish that you could do to up the health record game that we have, to change it, to improve it, so that actually becomes, one of the contributions of the administration to, the overall long-term health care of Americans?
Well, we are, and
Okay.
let me go back and tell you a story. And
So I didn't know that. I didn't get that note. But that's so. How are you doing that? Because it's really interesting.
And I'll start with a
Yeah.
story. So
Yeah.
we've been hearing about interoperability, but the whole issue sort of crystallized for me. I had an experience with my husband. He was traveling with our kids. I'm in a different city, and I get that call from my daughter, and she says, "Mom, we're in the airport. Dad's collapsed. The paramedics are here." And I get on the phone with
That's quite a call to get.
It was quite a call. And I'm on the phone with the paramedics, and they say, "Ma'am, your husband's not breathing. He's in cardiac arrest. Does he have any health care conditions? Is there anything in his medical record?" And I thought, I don't know. I didn't know. And it took me a few hours to get to him. And, but the bottom line was I didn't know. I didn't have his health care information. And then after a week at the hospital, he had all kinds of tests. They didn't know what was wrong. And, luckily he's fine. But when we left, I said, because this happened in Philadelphia, we live in Indiana, and I said, I need his healthcare records. Just can you get that for me? Because I'm, on my way. I'm busy trying to run run CMS and get this all situated. And I remember the doctor kind of looking at me like, uh-oh. And they came back with 5 sheets of paper and a CD-ROM. My kids were like, "What's the CD-ROM?" Because we don't even know what that is anymore. No one has that anymore. But it's, the federal...
Did they want to fax it to you, too?
Exactly. They fax the record. So we spent $36 billion, federal government, to have electronic health records. And when people leave, they're being handed paper. Fax machines are still in play. And so this administration is absolutely committed to this issue. We have a lot of support from the Office of Innovation, which is led by Jared Kushner. And we've taken a number of steps. For the first time, we finalized policy that if hospitals are not giving healthcare records to patients, they're going to be penalized. For physicians, where we give incentive payments, those incentive payments we've proposed to tie those to, are you giving the patient their healthcare record? We've also done a lot of our own work within Medicare, where we've said we have a lot of claims data that we have on patients, and we've now put it in an API format. And that's sort of a complicated way of saying we've put it in a format where patients can take that data. We are working with about 700 app developers to develop new and cool apps where they can take their information and it becomes meaningful for the patient. So they can organize their medication lists, they know which tests they've taken, they know which doctors that they've been to. They can take that information, understand it themselves, and they're going to be giving it to their physicians. And if we talk about healthcare costs, for a physician, they're not going to be duplicating tests anymore. They're hopefully going to have enough information that they're giving the right treatment at the right time because they have a complete record. So those are some of the investments that we're trying to make that we hope are going to turn the needle.
Speaking of technology, the other obsession I have about health questions is just the rapid speed of technological change. What we're seeing in the genetics area and the pharmacological area, it's truly staggering. How do you, given where you are and given the government, how does all of that sort of process in to kind of create equitable care and access across people? We know folks with resources can access the very best, but how do these major technological leaps that we're having today finally get processed, paid for, and how can regular people have access to more of these things that are coming online?
Well, that's one of the things that we're focusing on in terms of when we say we're trying to bend the cost growth curve. I mean, I do think that technology has the ability to offer that. We want to make sure our Medicare beneficiaries have access to the latest technology. So we've taken a lot of steps in terms of trying to improve our processes of working with companies that are developing new drugs and new therapies to make sure that we can expedite that. Which brings me to the point in terms of what we're trying to do to strengthen the Medicare program, which is why I think when we have conversations about Medicare for all, I think that's, absolutely a lousy idea. The Medicare program is intended and designed for seniors, and we need to do everything that we can to strengthen the program for seniors, deliver on the promise that we've made to these Americans that have worked their entire lives and depend on this program. We've gone from a program that has focused on acute care. Now it's focusing on chronic care. as people are living longer, we need to make sure that that program is structured and focused on the needs of that particular population.
I know this is a stupid question. I'm going to ask it anyway. I haven't looked at all the dimensions of Medicare for All, and I know it's a political football right now, but wouldn't you, in a way, solve some of the, I suppose, the risk pools, things that we debate about insurance and folks being left out and the kind of spikes in prices in terms of essentially finding a way to bring youthful folks that aren't a burden on the healthcare system in that? Or is that, what is really flawed in that reasoning?
Well, a couple of things. I mean, one, we know, we've seen the estimates. I mean, the price tag on this, some $32 trillion. It's not something that we can afford.
Right.
Dilutes the focus on seniors. But the other issue that I would say is that if we look
well, you'd go from a $1 trillion to a $32 trillion, yeah.
Well, yeah.
Some administrators would jump at that chance.
Well, I think a couple things.
Yeah.
What I want to stay focused on is seniors and making sure that they have a program that's going to work best for them. We don't want to dilute the focus. But if we look at the Medicare program, I mean, for years, the trustees have warned about the solvency of the Medicare program. Mm-hmm. And so instead of trying to fix some of the issues within the Medicare program and strengthen the program, putting more people into the program is not going to solve the problem and actually threatens the focus and the security of the program for seniors. I mean, if you look at the Medicare program, as you said before, it's not a value-based system. We're paying largely on a fee-for-service system. We don't even, if we look at our program integrity efforts, we're reviewing less than 0.5% of all of the claims that go through the system. We have 13 very complex payment rules. We pay for things differently. If you go to one location, we pay one price. If we go to another location, we pay another price. There's no coordination throughout the whole system on the fee-for-service side. So I think what we need to do is focus on strengthening the program, addressing some of those issues, and making sure that the Medicare program is sustainable over the long term so that we can fulfill the promise that we've made to so many Americans.
One of the things, look at, particularly from your perspective, and you see the kinds of trends that are facing Americans today. They're living longer. In many cases, like cancer, we've seen incredible turnarounds in some cancers, promising immunotherapy drugs. One of the, two of the areas that are hitting the United States right now is rapid growth in Alzheimer's, rapid, very big problems in opioid addiction. As you look at those kinds of things and look at how you're providing, what can you do in your role to shape the system so that it can withstand essentially these major pandemics and essentially tsunamis that are going to hit the healthcare system in coming years?
Well, that's a really important issue because I think that I always sort of look at CMS as we're the payer, right? We're at the end of the downstream effect.
But you're going to pay a lot in those cases.
That's right. And so when there are issues in a public health nature, whether it's a flu epidemic or the opioid crisis, we're going to feel it at CMS because we're paying for these services. I think the challenge for us is to not just look at, we're not here to just pay the bills.
Right.
We want to make sure that we are aligning financial incentives to make people focus on sort of the larger healthcare issues. So paying for value so that we're not just paying, here, and there, but we're creating a system that incentivizes providers to look at the big picture issue, and in terms of like the flu epidemic, looking at prevention, not just coming in and treating the illness of the day, but looking at the whole picture. Is this person prone to, are there addiction issues, and really kind of focusing on that larger issue.
We were just talking off stage about a system where there's too much inertia. Too many folks kind of doing things the way they've always done. We had a great piece, which I would recommend those of you who are into healthcare in the Atlantic, and I think she'll be here today. Olga Kazan wrote it. It was a wonderful, wonderful story of a year-long journey, essentially spending time with a woman in Baltimore, a very, very bright light, but had all sorts of healthcare challenges, was below the poverty line, and how the system was just stacked against her, and that despite her best efforts, and you put a lot of responsibility, this is a literate, capable, bright person, and really the bright spot of her family, but whether it was her own family or dealing with city services or state services, it was a miserable, miserable experience, and I still found her optimism great. And I'm interested in those kinds of stories and how you think institutions. You were at Johns Hopkins University, University of Maryland. We were looking at Baltimore and how age disparities, life span disparities were so huge within the Baltimore region, 20 years difference between some places and other, and that's correlated with race, correlated with income. I'm interested in just, step away from your administrator role. Given all you've experienced, what do you think we ought to be thinking more seriously about in fixing that problem that we're not, beyond politics?
I think we need to look at the whole person. I think there's been a lot of discussion about the social determinants of health, right? Understanding that when a person comes into the doctor's office, and it's not just about saying, here's your prescription, but really looking at the context of that person and all the issues that are going to influence their health. I think that's what the community engagement requirements are all about, right? Saying that, we need to help this person rise out of poverty, and to the extent that they have, they're working and they're more engaged in their community, they're going to have better healthcare outcomes. And so I think the conversation is sort of changing, and that's all about going to value, right? Because then when providers and the healthcare system aren't just treating every particular issue, but they're sort of saying, we're going to look at this person holistically. We're going to look at all of the things that are contributing to their health, whether it's where they live, their housing situation, their access to food, and all those things that are going to influence outcomes. I think when we start to change the healthcare system to focus on that, and that starts with changing the financial incentives. We've got to move away from a fee-for-service system and moving to one that goes towards value. When we start paying providers in a different way, we're saying we go in for your knee surgery, we're not going to pay you for every little service within the knee service. We're going to give you a bundled payment. And so you're going to be thinking about how to manage the person so that they're not coming back to the hospital, and when they're at home and they're recovering, that they have everything they need. They have the appropriate support services. So I think it's really incumbent on the healthcare system to change the way we're paying for healthcare, focus on value. And I think by doing that, we're going to incentivize providers not only to focus on the social determinants. You also mentioned technology and innovation. That's where we start to get into incentivizing providers to look at the latest technology and to be innovative. If we're going to depend on the government and CMS to say, okay, this procedure works, and we're going to pay for this, and we're going to pay for that, I think that becomes sort of weighs down the entire system. But moving towards value, where we say, here's your budget, and then providers are incentivized, look at the whole person, look at social determinants, and let's focus on being innovative. Let's use the latest technology and the latest treatments to deliver positive health outcomes and improve that person's life.
We're right near the end, and I could talk to you for another hour on faith and health, health literacy, and how you achieve it. We were discussing there's such disparity across the country when you move. I guess I want to give you a chance to take a whack at me and the media. What do you think we're not seeing in this healthcare picture in the way we report about Medicare and Medicaid? You're not exactly in a non-controversial area. What do you think we're not seeing that we might take a bigger look at to help us tell the story better than we are?
I think it's looking at the big picture. We always hear about, sort of the motivations. I know the administration's accused of sabotage, and I look at sort of our record on healthcare, for example, and over the last couple of years, since we've been in office, for the first time this year, rates in the individual market are going to go down by 2%. We had one of the best open enrollment seasons for the exchange program, and so while we're being accused of sabotage, look at the results, look at what's actually happening. I think also putting together the big picture, focusing on the cost of healthcare. I think that's something that we need to remind ourselves of every day, that as we are making changes for the greater good. We are making changes to sustain the system over the long term.
And I feel I should just ask this to add on. Do you think your predecessors got some things right?
Absolutely. Something's right, something's wrong, and I'm sure that folks will say the same thing about me when I leave.
Well, ladies and gentlemen, thank you very much. Seema Verma, Administrator, Center for Medicare and Medicaid, thank you so much.